Good to go, sir.
Okay. Good evening, friends. Welcome to our Tuesday webinars from the Department of Critical Care Medicine, Yashoda Hospitals. We bring forth these sessions regularly every Tuesday, which are interesting and they are across well received. And these interesting topics, most of the people they have given feedback, helped in their clinical decision, and they are coming as the forefront when to be as referred as the material. And today's topic of discussion is thrombotic microangiopathies in ICU. Even though it's a bit rare condition, but it is life-threatening. If you miss this condition, the patients definitely it's fatal, and sometimes if you miss the diagnosis, almost 90 to 100% of the mortality will be there. So to discuss this topic, we have expert panelist with us, Dr. Madhav Danthala. He is the senior Hemato-Oncologist and bone marrow transplant physician from Yashoda Hospitals, Somajiguda. He did his fellowship from Canada in bone marrow transplant. And our expert speaker today is Dr. C Misra, sir. So he is the senior consultant critical care medicine and head of the department from Yashoda Hospitals, Somajiguda. So we can go ahead, sir.
Yeah, thank you, Kaladar. As you told, thrombotic microangiopathy, it is a rare disorder. Mostly, I believe, after going through a lot of literature while preparing the slides and all, but I felt it may not be that rare. I think we are not suspecting more enough. And if we'll suspect in more and more cases, then we can find more and more thrombotic microangiopathy. And second thing, it is even more important. First, as I've told, maybe the numbers, whatever we believe, the thrombotic microangiopathy is there or prevalent in our ICUs, it is maybe much more than that. First, we need to suspect. And once we suspect, you see, this kind of patients mostly they will be admitted under some physician. So it becomes very difficult initially to suspect. Once you suspect, you send the initial evaluation, and it is paramount important. As you told, the mortality is very high in these patients having thrombotic microangiopathy. We need to involve our hemato-oncologist or hematologist as early as possible to have a proper plan and maybe treatment. See, these are like kind of thrombotic microangiopathy treatment per se, not the diagnosis. Treatment is very complicated, and as a critical care physician, we are not exposed to those kind of the treatment plans and all those things where our hematologist friends will be of the most helpful. So different maps are being used capsulizumab, vaclizumab, rituximab, all those maps, this monoclonal antibodies and all those things are coming up in a big way. So thrombotic microangiopathy, the name suggests, coming to the topic itself, let's say thrombotic, as we know, like thrombus. So the formation of thrombus, micro means small, angiopathy means small vessel inflammation. So most of the time, TMA is a much bigger umbrella than what we can think of. But most of the time, whenever we think of TMA, we think of TTP, thrombotic thrombocytopenic purpura, maybe hemolytic uremic syndrome, complement mediated TMA, or atypical HUS. The name atypical HUS is now slowly being weaned off. They are telling that there is nothing atypical about it. It is the complement mediated TMA, which is otherwise called as atypical TMA. If you see, these are the main thrombotic microangiopathy called as primary microangiopathies, but there are many other things what we are not aware of. Malignancy, let it be solid tumors, let it be lipoproliferative tumors, even myeloma also can present with thrombotic microangiopathy. Different infections, including your HUS, which is because of Shiga, dysentery, or some form of hemorrhagic E. coli. Other than that, there are many other infections we'll come across in the future slides that can lead to thrombotic microangiopathy. Many autoimmune diseases, mostly what we see in our ICU is SLE. Sometimes we see APLA and catastrophic APLAs, even scleroderma, which causes renal limited thrombotic microangiopathies. Transplant, let it be solid organ transplant or hematopoietic stem cells transplant, that itself can produce thrombotic microangiopathy. Pregnancy, one of the most common like pregnancy-related issues, which is one of the most common presentation into our ICUs, can itself present with the thrombotic microangiopathy. And one more important factor, what we most of the time miss, that is a drug-induced thrombotic microangiopathy. Believe me, there are so common drugs what we use day in and out in our ICU can produce thrombotic microangiopathy. There are many other things like metabolic thrombotic microangiopathy, where there will be B12 metabolism issues, homocysteine deficiencies. There are many other things which is very difficult to cover everything in maybe next 30-40 minutes. We'll try to touch most of the things, and we'll discuss little more how to approach a case of thrombotic microangiopathy and more common primary thrombotic microangiopathies, maybe in little more detail. So basically, what we mean by thrombotic microangiopathy, if you see the main thing, what happens is some form of endothelial injury, or the cornerstone of a thrombotic microangiopathy is some form of endothelial injury which lead to platelet activation and consumption, contribute to the microvascular thrombosis. Whenever the platelets activation and consumption means platelets will get aggregated in your endothelium, wherever there is an injury, that will cause microvascular thrombosis, which will occlude those small arterioles by lead to tissue ischemia and subsequent end organ damage. If you see this picture, in this picture, you see an arteriole where the whole of the intima is deposited with fibrin and platelets, occluding the whole of the arteriole, which will lead to some form of ischemia and end organ damage. This is a light microscopy of a glomerulus. This middle one, whatever you see, these are the small arterioles which are being blocked because of glomerular thrombus. So this will lead to acute kidney injury. Mostly we see in hemolytic uremic syndrome and maybe renal limited scleroderma also. So TMA, basically what happens, whenever there is injury to the endothelium, there will be aggregation of the platelets. Because of the aggregation and consumption of platelet, there will be thrombocytopenia, and there will be narrowing of the blood vessels. Because of the narrowing of the blood vessel, while the RBCs are passing through, they get destroyed. They get having some injury to the RBCs, because of which we found different forms of RBCs, not the regular what we regularly see, the elliptical or the circular one of RBCs. So basically, because of this, while traversing the RBCs which get traumatized or injured, that will lead to microangiopathic hemolytic anemia. There will be hemolysis, which is intravascular hemolysis. Second thing, because of consumption of platelet, there will be thrombocytopenia, and because of obstruction of your arterioles or small vessels, which will lead to end organ damage. So these are the three main factors when it comes to thrombotic microangiopathy. Any patient presenting with some form of MAHA or microangiopathic hemolytic anemia plus thrombocytopenia, we need to suspect it may be a case of TMA. TMA actually is a pathologic diagnosis, so we have to suspect. To diagnose it with 100% surety, we need to do a tissue biopsy. And typically, most of the time, kidneys are involved. It's not the only kidneys involved, but thrombotic microangiopathy can involve any organ, including your brain, your lungs, your heart, your GI system. But even if there are multiple thrombus in the lungs, usually they don't present with pulmonary symptoms. So coming to MAHA, this is microangiopathic hemolytic anemia. As I told, it is the intravascular hemolysis which is going on, which is a non-immune hemolysis. There is no antibodies formed against your RBCs causing hemolysis. It's typically non-immune hemolysis, where the intravascular red cells get fragmented, and they give rise to those fragmented RBCs, typically called as cystocytes. The small arterioles, as I've told before, the small arterioles and capillaries are frequently involved. Large arteries and all are frequently spared in these cases. Sometimes we can see MAHA whenever we have intravascular devices like prosthetic heart valve or assist devices also. Even the patient who is on IABP or somebody who's on ECMO also can have microangiopathic hemolytic anemia. See, typically a picture, if you see a peripheral smear, these are called helmet cells. These are all fragmented red blood cells. These are the cystocytes, fragmented RBCs and all. And these are called microcytes. So there are, because of fragmentation of RBCs, you can see the number of RBCs in this smear is less. So because of which they will develop anemia, and different fragmented RBCs and different shape and size that we can see because of intravascular hemolysis. So if you see the lab data, when in a case of microangiopathic hemolytic anemia or thrombotic microangiopathy, first thing, as I have told, is a non-immune hemolysis. So there should be negative DAT or Coombs test, direct Coombs test will be negative. That is the first thing. If Coombs is positive, we need to think in terms of a immune hemolysis or autoimmune mediated hemolytic anemias. Because of hemolysis, the lactate dehydrogenase will be high. Indirect bilirubin will be much higher when it comes to a hemolytic patient, and because of hemolysis, haptoglobin will be utilized, so haptoglobin levels will be low. How we should approach to a case of TMA? This is very, very important when you suspect TMA, how we should approach to a case of thrombotic microangiopathy. So these people can present to you with a variety of presentation. If it is, let's say, a insidious onset, most of the time they can present with unexplained anemia and thrombocytopenia. They may not have any other symptoms. They sometimes this TTP, thrombotic thrombocytopenic purpura people can present with neurological finding, because in TTP we see more often central nervous system affection. So these people can present with stroke, transient ischemic attack. And we see in other forms of thrombotic microangiopathy where acute kidney injury more pronounced. They may have GI symptom, they may have cardiovascular symptom or other non-specific symptom. As I've told, the suspicion of TMA is more important. Otherwise, we'll miss a lot of thrombotic microangiopathy. Maybe they are happening in our ICU, but still we are missing those if they are not severe enough. The initial evaluation is focused on only two things. One, you should prove that there is a microangiopathic hemolytic anemia is going on and thrombocytopenia is there. If these two things are there, then we should think of TMA. Whenever you think of TMA, you should rule out other systemic disorder which can have similar kind of findings. If those things are not there, then you have to think of TMA. So if you see a pathologic evidence of TMA, as I've told, like MAHA and thrombocytopenia, the more commonest one or the primary TMS are TTP. TTP can be congenital or immune. Congenital, where there will be ADAMTS13. I will come talk on those things maybe in next few slides. ADAMTS13 mutation will be there. Immune mediated, where there will be autoantibodies against ADAMTS13. And complemented mediated TMA, or what we say in a broader sense was atypical HUS. So in complemented mediated, there are many your genetic and autoantibodies are implicated to give rise to complemented mediated TMA. The most common ones what we have seen is CFH. Antibody mediated against CFH also is one of the more common reason where patient can develop complemented mediated TMA. There are variants, non-complemented genes also which can give rise to complemented TMA. Infection associated like cigatoxin and many other infection will come to those things in the later slides, which can give rise to TMA. Secondary to many systemic diseases and different exposure to drugs can give rise to thrombotic microangiopathy. So if you see, these are the few listed things where we can see thrombotic microangiopathy. ADAMTS13 mediated TMA, that is called TTP. It may be congenital immune, as we have discussed before. Complemented mediated TMA, it can be congenital immune. Most of the time, like before, we used to call it to be a typical HUS. Coagulation mediated, different because of coagulation abnormality, one patient can give rise to TMA. Metabolic, where the defect of cobalamin metabolism, B12 metabolism can give rise to thrombotic microangiopathy. Different infection, as I have discussed, many bacteria like your E. coli, Streptococcus, Campylobacter, Klebsiella, virus like influenza, HIV is very, very important. CMV is very important when it comes to thrombotic microangiopathy. A lot of viruses, fungal histoplasmosis, even your aspergillosis and candida also is implicated to give rise to thrombotic microangiopathy. Pregnancy associated TMA like your preeclampsia, HELP, even pregnancy can trigger TTP and complemented mediated TMA and catastrophic applause. Other like drug-induced are maybe most of the time we are missing it. It may be immune mediated, non-immune mediated. Immune mediated can be have antibodies against platelet and neutrophil like gemcitabine, trimethoprim, sulfamethoxazole, and quinine, vancomycin. All those things can cause immune mediated. And ticlopidine is one of the drug which is more often used in cardiac cases, which can have produce autoantibodies against ADAMTS13 and present like a case of TTP. Non-immune directly, this like most of the chemotherapeutic agents like gemcitabine, mitomycin, vincristine, doxorubicin, all those things can cause non-immune mediated TMA, where they can directly have some endothelial injury giving rise to your platelet aggregation and signs of thrombotic microangiopathy. Immunosuppressive therapy like calcineurin inhibitor like your tacrolimus and cyclosporin, sirolimus, all those things can give rise to non-immune mediated TMA. Transplant associated TMA, solid organ and hematopoietic stem cell transplant itself can give rise to thrombotic microangiopathy. And malignancy can give rise to TMA, and autoimmune diseases, as I told before, like your scleroderma, APLA syndromes, or catastrophic APLA, even SLE can give rise to TMA. Apart from that, severe hypertension, when there is a hypertension emergency, where the blood pressure is beyond 180, 190, these people can present with TMA. So how we should approach? First thing is you should suspect TMA when there is a microangiopathic hemolytic anemia, there is thrombocytopenia. Because of anemia, there will be reticulocytosis as the bone marrow has not been affected. And because of hemolysis, there will be LDH which is elevated, bilirubin with mostly indirect bilirubin will be elevated, low haptoglobin, and we see cystocysts in the periphery. These things are there. We need to suspect MAHA. And whenever we are suspecting thrombotic microangiopathy, we need to exclude the other diagnoses like autoimmune hemolytic anemia by doing a direct Coombs test, which has to be negative. DIC, which can present with TMA, but their treatment or maybe the precipitating factor need to be treated, where we know that in DIC there will be other coagulation factors also will be abnormal, like your PTI and repetitive, the D-dimer fibrinogen level will be low. Assays of renal and external and organ damage also need to be seen, because TMA, as I told, can give rise to end organ damages. Once you prove that there is a thrombotic microangiopathy, the first step what we need to do is to exclude thrombotic thrombocytopenic purpura. So whenever you are suspecting TMA and you have ruled out other causes which can present like TMA, first thing is to exclude TTP, because TTP, if we are not treating them early with a plasma exchange, we'll come to those things in maybe next 3-4 slides, the mortality can go up to 90%. So whenever there is a TMA has been proved, first thing what we need to do is to exclude TTP. Send a ADAMTS13 activity, and most of the time we see if it is less than 10%, it fits into TTP. But we should not wait. If you have doubt, better to start a plasma exchange early than late, because these people will not going to give you much time. If TTP is excluded, the next thing what we need to do is exclude different form of infections. So there we need to send maybe stool toxin for SIGA, cultures imaging. Sometimes we need to do variety of viral testings, including HIV. All those things need to be done to rule out the infection which can present with TMA. Once infections are ruled out, we need to go with other rare causes like autoimmune diseases, metabolic like B12 and homocysteine level, pregnancy, because pregnancy can present with TMA. Once all those things are excluded, then comes the complemented mediated TMA. There are many genes and autoantibodies are implicated to give rise to complemented mediated TMA. Let's discuss in short the common TMS, what we come regularly or we should suspect in a case of TMA in our ICUs. One of the most common one, or maybe most of us are aware of, that is called thrombotic thrombocytopenic purpura or TTP. Usually develops in the setting of ADAMTS13 deficiency, where the activity is usually we say to be less than 10%. It is not always that if we are suspecting TTP, the ADAMTS13 has to be less than 10%. Even if it is 10 to 20%, even 20 to 30% also, they can have TTP. And few other conditions where the ADAMTS13 levels might be less than 10, but still they may not have TTP. ADAMTS13 is a very, very important enzyme which cleaves the highly thrombogenic 1-Wilbrand factors. So 1-Wilbrand factors are ultra-large multimers. If your deficiency is there, those Wilbrand factor will start widespread accumulation in the vessels, which will lead to widespread platelet aggregation and thrombosis. So this thrombosis of platelet will give rise to MAHA and thrombocytopenia. So TTP, as I have discussed before, can be congenital, where because of homozygous or compound heterozygous variants of ADAMTS13 gene can be there, or immune mediated, which is much more common. And whenever we see in adult patients TTP, most of the time it is because of immune mediated TTP, where there is autoantibodies against ADAMTS13. When you should suspect TTP, as I've told, the suspicion of TTP is very important. Is like if you are delaying the treatment, mortality can go very high. There is a score called plasmic score, where they see platelet count. if it is less than 30. TTP is one of the condition where in the umbrella of thrombocytopenic, like your TMAs, where platelets counts are significantly low in TTP compared to most of other forms of thrombotic microangiopathy. And TTP is one of the TMA where kidney involvement is usually much less compared to other forms of thrombotic microangiopathies. So creatinine should be less than 2, and there should not be any other coagulation defect. Mixed, your MCP should be less than 90, and there should be signs of hemolysis. There should not be any active cancer, or there should not be any stem cell organ transplant. So there are 7 points to see. So out of 7, when your score is 6 to 7, then the ITP TTP risk is very high. So you need to send ADAMTS 13 levels and immediately ask for the consult, like hematologist opinion, and you need to think of starting the therapeutic plasma exchange as early as possible. If it is intermediate, when the score is 5, there also you need to send ADAMTS 13 and take a hematologist opinion, and in these cases also you may need to start plasma exchange early. If the score is low, like score is 0 to 4, then you need to think of alternative diagnosis, and most of the time you don't require to send ADAMTS 13 also. So how we should manage a case of TTP? So we should have a low threshold for starting plex, as I have told earlier. If you are diagnosed to have TMA and you are suspecting TTP or TTP is high on your cards, better to start a plex early than late, because mortality goes very high without plex. In a case of congenital TTP, these people don't present with that severe form of thrombocytopenic purpura what we see in adults because of immune mediation. These people can be treated by intermittent plasma infusion itself. There is a newer drug called caplasizumab, which is a humanized monoclonal antibodies that targets your 1 million factors and prevent the weird 1 million factor and platelet interaction. So it prevents platelet aggregation over your VWF, 1 million factor. But caplasizumab is, I don't think is available in India. It is a very costly drug per se. So we are left with mostly plex. So now coming to other more common one, that is hemolytic uremic syndrome. In this cases, again, I've told like TMA, there has to be Maha thrombocytopenia. When it comes to HES, acute is much more profound compared to your TTP. This is one of the differentiating factor when it comes to HUS versus TTP. In HUS, we see mostly kidney involvement is significant. In TTP, we see neuro involvement or central nervous system involvement is more common with TTP. And HUS, more often we see in pediatric age group and infants, cigatoxins in Shigella dysentery or some form of hemorrhagic E. coli like O157, H7 and O105 and H4. They are the more common organisms. If they are, one person is getting infected, can give rise to HUS and TMA. Cigatoxins can directly damage the kidney epithelial cells, kidney mesenchymal cell, and vascular endothelial cell. This happens because of GB3 receptor, where the cigatoxin is very effectively and avidly attached to the GB3 and go out of your endothelium to attach to the organs where GB3 receptors are more profound, like your kidney and vascular endothelium, and injure them. There has to be a history of exposure to farm animals, like there has to be some undercooked meat and inadequate clean commercial prepared vegetables and contaminated water history should be there. And these people initially present with severe form of acute gastroenteritis like severe abdominal pain, nausea, vomiting and diarrhea. And later, at that point of time, they don't present with signs of thrombotic microangiopathy. Over a period of time, over 8 to 10 days, when these symptoms tend to resolve, then they show signs of kidney injury, microangiopathic hemolytic anemia, and thrombocytopenia. So different other forms, as I've told, can give rise to Maha and thrombocytopenia, different infections. This slide I've taken from UpToDate. If you see multiple gram-positive rickettsia, Borrelia, Brucella, Chlamydia, Clostridium difficile, E. coli, Legionella, there are many bacteria which can give rise to a thrombotic microangiopathy. Many viruses, I've told, HIV is one of the important ones, CMV, Parvo, EVV, all those things can give rise to TTP. Aspergillus, Candida, Cryptococcus, in RBC, parasites like Babesia and malaria can give rise to thrombotic microangiopathy. So when it comes to any form of infection related TMA, they don't require any form of plex or maybe your different monoclonal antibodies. These people usually require supportive treatment. You need to hydrate them properly. If your hemoglobin is low, they may require transfusion. If acute kidney injury where there is no urine output and all, they may require dialysis. So basically they require supportive management other than like plex or any other high-end modalities. Coming to the complemented mediated TMA, or what is called as atypical HUS more commonly before, but nowadays we are calling them as complemented mediated TMA. It is a much more complicated and maybe difficult to diagnose form of TMA and more implicated in many other conditions apart from your TTP and maybe in HUS. So here also, most of the time we see signs of thrombotic microangiopathy, and these people more often present with severe form of acute kidney injury. And when we should suspect a complemented mediator, this should not be associated with diarrhea and all. There should not be association of cigatoxin. And this is mostly because of complements. As we know, complements are the first line of defense for any form of infection. That is, complements are the main form for innate immunity. If you coming to the complement, there are three pathways: classic pathway, alternate pathway, and lectin pathway. The three main pathways by which the complements get activated, and because of which the antigen presenting cells and all those things, the first line of defense for all bacteria and viruses which attacks to a human body. But sometimes this, if they become dysregulated, they can affect the endothelial and other organs also. And most of the time, when it comes to complemented mediated TMA, the alternate pathway is most of the time, which is more active, causing injury to self endothelium and other organs, and which will maybe, but it's not always alternate pathway. Even classic and lectin pathway also can give rise to terminal pathway by which we can have uh, injury to self. So basically, complemented mediated TMA, the cornerstone is complemented dysregulation, which is the predominant mechanism for endothelial injury. Usually, this diagnosis of complemented TMA is diagnosis of exclusion. There are many genes and autoantibodies against CFH, CFI. There are many things has been implicated to give rise of complemented TMA. The list whatever I've shown is very limited. There are many other things which can give rise to complemented mediated TMA. CFH, autoantibodies and inactivation is one of the more common cause where a person can develop complemented mediated TMS. When it comes to complemented TMA, complemented mediated TMS, the treatment eculizumab is a anti-C5 monoclonal antibody which has been widely approved for complemented mediated TMA. But unfortunately, this eculizumab is not available in India. If you want to treat your patient who have some complementary mediated TMA with eculizumab, you need to order those from some Western countries, and the cost is significantly high. One dose may cost beyond 1 lakh, and this drugs has to be used weekly once. And if you see, the optimal duration of treatment remains unknown, and sometimes they may require for 6 to 12 months. Every month, the cost may go up to 6 to 10 lakhs or 12 lakhs. It's very difficult in Indian scenario to start off eculizumab because it is not available. Even if you are procuring it from outside country, it's very difficult because of the uh, cost issues. Plex can be considered in patients with life-threatening end organ damages, even if it is a complementary mediated TMA. The first line of therapy, which has been suggested worldwide, is eculizumab, which is very difficult in Indian scenario, as I've told before. The Plex can be tried, and patients with anti-CHF antibodies may also benefit from TP or therapeutic plasma exchange and immunosuppression, like rituximab and cyclophosphamide, to clear the circulating antibodies. So what to do when you suspect complementary TMA or this atypical HUS in Indian scenario? In Indian scenario, I think we have left with only one thing, that is Plex or plasma exchange or therapeutic plasma exchange. But the literature says if you use plasma exchange alone, these people, the recurrence rate is high and end organ damage. Sometimes this AKI can lead to CKD in these cases. One of the next more important thing what we we come across more often in ICU is pregnancy-related issues. That is pregnancy-associated thrombotic microangiopathy. There are three distinct TMA etiologies can be found in pregnancy. One is complement-mediated TMA or atypical HUS, HELP syndrome, and TTP. TTP, the patient, because of pregnancy itself or some infection and inflammation, can predispose a patient who is having pregnancy to TTP. So others like CAPS, like catastrophic APLA or even SLE flares are more common in pregnancy. Renal cortical necrosis, one of the things which can present similar to a thrombotic microangiopathy, and usually this renal cortical necrosis happens in patients of DIC, and DIC is more common in pregnancy because of many reasons. Let it be infection, let it be amniotic fluid embolism, or intrauterine death. All those things can cause DIC, which can lead to renal cortical necrosis. We have seen recently one case where there was bilateral renal cortical necrosis and signs and symptoms of TMA. So preeclampsia and HELP, where there are, again, we know there is issue with the spiral arteries and there will be placental ischemia. Whenever, as we have told, the cornerstone of the TMA has to be some injury to the endothelium. So in preeclampsia and HELP syndrome also there will be some injury to the endothelium, which can give rise to your signs and symptoms of TMA. And even in pregnancy, they can have aberrant complement activation. TTP may present during pregnancy, typically in the second and third trimester, and most of 1/4 of such cases can be congenital. How to treat? The first more important part is you have to distinguish pregnancy associated it is because of TTP, complemented mediator, or HELP syndrome, because the treatment for each and every of these conditions may differ. So if you believe it is a congenital TTP, plasma infusion should suffice. If it is a immune-mediated TTP, you need to think of plasma exchange as early as possible, because the plex in pregnancy, there is no difference between a normal person or a non-pregnant lady. Complement-mediated TMA, plex to start, because no, like we have to rule out like it is not TTP. So you better to start a plex. Once you are confirmed to adenosine report, you may consider eculizumab if it is available. Otherwise, you need to think of plex only. Preeclampsia and HELP, as we know, all of us, like we need to deliver the baby as early as possible, because that is most of the time that itself will suffice. But if you are suspecting preeclampsia and HELP, we know that that is much more common in pregnancy and pregnancy-related or obstetric-related emergencies. If after delivery also the MAHA is not resolving, then you need to think of other underlying causes. Most of the time, it will be complement-mediated thrombotic microangiopathy. Drug-induced TMA, drug-induced can be immune-mediated and non-immune-mediated. Immune-mediated drugs, as I've told before, can have autoantibodies against platelet and neutrophil like gemcitabine, oxaliplatin, trimethoprim, sulfamethoxazole, quinine, vancomycin. They are common drugs, but to use can cause immune-mediated injury to the platelet and giving rise to signs of TMA. Autoantibodies against ADAMTS13 can be produced if you are using teclopidine, which can present like a TTP. Non-immune mediated, many chemotherapeutic, immunosuppressive, and antibiotic like Cipro, Levoflox, metronidazole, all those things can cause non-immune mediated damage to your endothelium and giving rise to signs and symptoms of TMA. So coming to the drug induced, the only thing what is required is you need to identify the offending drug, and if you stop that drug, most of the time the TMA resolves. Some patients who developed immune-mediated thrombocytopenic purpura because of ticlopidine, these people may require therapeutic plasma exchange. Otherwise, TP in the other forms of non-immune DITMA, they don't require anything. Coming to few of the autoimmune diseases, now because of the restriction of time, I'll just touch upon few of the autoimmune diseases like CAPS, catastrophic APLA syndrome, is like many things which can produce a APLA, and it can give rise to catastrophic APLA, where we see multi-organ dysfunction, DIC, and thrombotic microangiopathy. And these people, they develop all those things within a week time. That is how we diagnose it to be a catastrophic APLA. And in catastrophic APLA, they will have autoantibodies against platelet, leukocyte, and endothelium, because of which they may have endothelial injury, thrombocytopenia, and signs of thrombotic microangiopathy. Apart from that, in CAPS, they can have complement activation. Usually, when we suspect CAPS, the treatment first is anticoagulation because of widespread thrombosis and organ dysfunction. Second, you need to start immunosuppression, and in these cases, there is a role of IVIG and plasma exchange also. Scleroderma, renal crisis. Scleroderma is a autoimmune disease where they can have renal limited thrombotic microangiopathy. Even if there may be thrombus in other organs also, they usually present with acute kidney injury because of renal endothelial injury, and there will be a significant RAS activity, and because of which there will be severe vasoconstriction. And the treatment for scleroderma, most of the time they present with severe hypertension or hypertensive emergencies. The treatment will be SE inhibitors to control the hypertension and RAS activity. SLE can present with thrombotic microangiopathy when it comes to a SLE flare, and the treatment we all know in SLE we give maybe immunosuppressants, and sometimes flex or IVIG can be used. Other rare causes like hypertensive emergency. If somebody's BP is very high, that itself can cause shear stress on the vessels, giving rise to thrombotic microangiopathy. The only treatment required is control of the blood pressure. Different form of cancer, as I told before, solid tumors, lymphoproliferative tumors, and myeloma can give rise to TMA. The cancer itself can give rise to TMA, and we have discussed like multiple like immunosuppressant and cancer treatment. All those things can give rise to thrombotic microangiopathy. Transplant associated, so different form of transplant. Let it be a solid transplant like your kidney transplant cases, they can have higher chances of TMA, or hematopoietic stem cell transplantation patients also can develop thrombotic microangiopathy. Calcineurin inhibitors, what most of the time we use in transplant patients like your tacrolimus or cyclosporin, can give rise to TMA, which mostly is a drug-induced thrombotic microangiopathy. The treatment in transplant-associated thrombotic microangiopathy is most of the time IVIG, eculizumab, and sometimes plasma exchange also can be used. So coming to my last slide, the take home, it is as I've told, TMA is a pathologic lesions identified in a spectrum of life-threatening conditions. As I've tried to touch upon the spectrum, at least you should have some idea. It is not only TTP, HUS, and atypical HUS. There are many other conditions and infections, drugs, autoimmune diseases, many things which can give rise to thrombotic microangiopathy. So the spectrum is very wide, and it's much bigger. The spectrum is much bigger than the most common thing what we suspect most of the time, TTP and HUS. Complement dysregulation is a feature in many syndromes associated with TMA other than your TTP and HUS. Potential role of crosstalk between the coagulation and complement pathways, which we believe may be one of the most common reason to develop thrombotic microangiopathy, is an area of active investigations. The high mortality and morbidity in this thrombotic microangiopathy patients mandates rapid and accurate diagnosis. At least you should suspect early, and timely starting appropriate treatment can save many lives and prevent permanent organ dysfunctions. With that, I will close my talk here. Thank you very much for your listen hearing. Thank you. Over to you, Dr.
Thank you, sir. Sir, yeah, thank you very much, sir, for that elaborate discussion, which focused almost covered entirely on different causes that can lead to TMAs and how to deal with them. And thank you for the very good presentation, sir. So, Dr. Madhav, sir, are you there?
Yes, I'm there.
Yeah.
Can you hear me?
Yes, sir. Yes, sir. We can hear you, sir.
Yes.
So,
yeah, please go ahead.
Yes, sir. So we'll start the discussion. That basically, when we were having like the students, there was a classical teaching that the TTP will be associated with the pentad of fever, altered sensorium, severe neurological manifestations, acute kidney injury, MAHA, and thrombocytopenia. Do you think that this has to be the criteria that has to be met when one should consider, before one should consider the possibility of TTP? What do you think, sir, about the pentad?
I think that's a wonderful question to start off. So the classical pentad is not present in most patients, I would say. The point you have to understand about TTP is it's remarkable, it's remarkably diverse in its presentation. So patients with TTP may have no symptoms and they can have a normal physical examination, right? So the topic itself is TTP in ICUs. which might lead you to think that patients are extremely sick or warranting an ICU admission, but most of them don't have symptoms and they can have a normal physical examination. And TTP can be suspected by unexpected severe thrombocytopenia and anemia on a routine CBC. Okay, that's one thing. Second, the most important point that you have to understand is patients with TTP may die suddenly, even when they've had minor symptoms only for 1 or more days. So don't always expect to see the classical pentad in all patients. It needs a high index of clinical suspicion. And also TTP can occur initially with an additional disorder. So context is important, right? Is it transplant associated? Is it associated with a cancer? Is it associated with pregnancy or an autoimmune condition or on the background of an infection? So all of these things are important. Context is important, but don't always expect to see the classical pentad and don't always expect that your patient is critically ill for you to make a diagnosis of TTP. The other important point that Dr. Misra briefly touched upon was you cannot rely on ADAM-TS13 to make a diagnosis of TTP. So the ADAM-TS13 is going to take time. So you're not going to wait for the levels before initiating treatment. It may be too late if you wait for the levels. And it's not just that you can, you may not always have an activity of less than 10%. Sometimes you can have TTP even in the presence of a normal ADAM-TS13 activity of more than 60%. So that does not exclude a diagnosis of TTP, right? And sometimes ADAM-TS13 activity of less than 13%, 10% may reveal unsuspected TTP. Now, the problem is ADAM-TS13 as a functional assay, as a test, is an extremely complex test. So there's always a chance that you can have false results from ADAM-TS13. You may go on to do an ADAM-TS13 antigen assay, but that's definitely an important point to remember. So I hope that answers your question. Don't always look at the classical pentad to make a diagnosis of TTP. The moment you see MAHA, the moment you see thrombocytopenia, you see cystocytes on the smear, you see some evidence of non-immune hemolysis, and you see, make sure you suspect TTP and act on it.
Yeah. Yes, sir. Yeah. Thank you, sir. So generally, the decision, because we need to initiate these patients as an urgent basis on therapeutic plasma exchange. So sometimes you're worried whether really you're confident that the diagnosis is being TTP or most of the time they are the TTP where you will initiate. So how to differentiate, sir, between these thrombotic macroangiopathies? I think Mr. Sir stressed upon those things, probably to make it as a brief. So the classical patient where you think, yes, I can go ahead with therapeutic plasma exchange. There is no waiting like that. So how do you take this clinical decision at the bedside?
See, when you look at the treatment options that are available, right? Apart from plasma exchange, plasma infusions, some amount of immunosuppression with corticosteroids and Ritux, we don't really have, access to eculizumab and caplacizumab. Eculizumab is going to take time to import, so you need to make a quick decision. So again, context, finding MAHA, finding unexpected thrombocytopenia. If you find any neurological involvement, if you find renal involvement, and these are not just the two organs that are involved, sometimes you can have cardiac involvement as well. If you go through a lot of data with TTP, the patient does not always have neurological. There are patients who've been diagnosed with TTP at autopsy, and the only involvement is cardiac. So you also have to look at the cardiac enzymes. You do a TROP, do the 2D echo, and these things. So context is very important and need to act on it. And there's absolutely no harm in proceeding with Plex at the earliest, right? The other more important, yes, sir, Mr. Sir, do you want to interrupt?
No.
Yeah, do you want to inject?
Continue.
Yeah. Second, the response to Plex is also very varied, right? That's one of the other diverse things with TTP is that you cannot really predict the response to Plex. You may have a patient who might respond wonderfully with just one session of Plex. You might see, you might follow up the parameters, hemolytic parameters, and see significant improvement. You can see an improvement in the platelet counts right away. The LDH is going to drop, and then that might, suggest that there's definitely, it's worth continuing more sessions of Plex. There might be patients who require multiple sessions of Plex to try and get the disease under control, and might still be someone who might relapse very soon. Right, so it doesn't mean that if a patient responds just to a single or two sessions of Plex, that's the patient who's going to be in continued remission. So that's one of the uncertainties, right? Also, one of the things we do in the ICU on a practical standpoint is, if we are convinced that it is a diagnosis of TTP, right, both context and the clinical manifestations, we almost always go ahead with Plex and check if, maybe there's a slight improvement in the lab parameters, or there's a slight improvement in the clinical condition of the patient, that might push us to continue with the Plex. So it's ultimately a matter of clinical judgment. That's the reason why we have all of these talks. But you have to make that decision, and there's no single parameter that's going to guide you as to whether to start Plex or not in a given patient.
Yeah, perfectly told, Dr. Madhav. Actually, I was going across in the critical care physician, we always felt like if it is TTP, there has to be a pentad or most of the things in the pentad. But after going through a lot of literature, pentad is not there anymore. Believe me, most of the literature, they have not mentioned about pentad itself. So if it is a TMA, the first thing you should rule out is TTP because of the high mortality. And maybe you, in benefit of doubt, you better start off plasma exchange. And I missed one thing in my talk. So the two things, even like Dr. Madhav told, like it is not only the brain which is more often involved, it can involve any organ. In autopsy, they have seen thrombosis in most of the organs, even in the lung. But interestingly, even if there is thrombosis in the lung, most of these people, they don't present with pulmonary symptoms. That is again a unusual presentation, but still that is there. The lung may be affected, but usually they don't present with pulmonary symptoms. Cardiovascular, GI, everything can get involved. And as Dr. Madhav told, you have to start Plex early, and maybe multiple cycles they may require. And the cycle, like in other like GBS and other forms of acute like myasthenia and all, where we use plasma exchange, we do it around 5 or 6 cycles, we'll stop it there. But in case of TTP or maybe in other forms of TMA, if you start, you need to see the recovery of the platelet. And the platelet, as per the definition, if it is more than 1.5 lakh for 2 to 3 days, that is the time when you should stop Plex. Till that time, you may need to continue plasma exchange in these cases.
Yes, sir.
So that's the other point of discussion, right? When do you stop Plex? For how long do you continue Plex? One factor that Dr. Mishra mentioned is definitely a platelet count. Also, if you have a patient who has renal involvement, don't expect that the patient is going to have complete recovery of renal function and is going to go off dialysis. Even if you have a stable creatinine for, say, 3 consecutive values, you could still try and stop Plex. The other point worth considering is there are a lot of studies that have looked at adding treatment to Plex instead of just going for Plex alone, maybe adding Ritux or other immunosuppressive agents to see if that decreases the chances of a relapse, right? Even those are not too encouraging, because there's no single study that has demonstrated that maybe adding rituximab or another immunosuppressive drug is going to change the long-term outcomes. So it's very frustrating to have a condition where you don't have clear-cut answers to all your questions. And I think as physicians, we always looking at, we get very jittery when we don't have that kind of evidence. Also, another important point worth mentioning, I think that was not covered in Dr. Mishra's talk, but it's worth mentioning is, Sir did touch upon that. He did say that, you can have a patient who has low ADAMTS 13 activity and may still not have TTP, right? TTP in the sense he might not have symptoms of TTP. So that's also very commonly seen during the follow-up phase. You might have a patient who has low ADAMTS 13 and doesn't have a relapse, doesn't have a recurrence of the clinical symptoms, right? So then that makes it difficult to kind of judge which is the patient who might require, rituximab in between, or maybe eculizumab if you have access to it. So we always, there's always a question of whether you can go ahead with a preemptive approach. Stop the plex, keep the patient on follow-up, continue to monitor the ADAM TS13 levels. If it starts dropping, then maybe that's a sign that you should intervene, right? Maybe at that point you could give him a dose of rituximab or give him a dose of eculizumab. So that's the other point that has to be kept in mind. You cannot always follow up the ADAM TS13 levels both upfront and in the follow-up period and make clinical decisions. The only context I think where it's reasonably, there's some amount of clarity is I think pregnancy associated TMA, right? Where the differential diagnosis again is HELP. You could, as part of HELP, you have to distinguish between DIC, distinguish between TMA, and we've had quite a few patients where even in that circumstance you've had some confusion. But the moment the patient you take the patient for an elective section, and within 48 hours you see recovery, then you're certain that it's HELP, right? And if it continues to be you don't see the expected improvement, then that's when you have to go ahead with Plex. Also, the other very commonly associated thing is we're transplanters, right? So cyclosporin, tacrolimus, and so for calcineurin inhibitors, you always continue to monitor to look if there's MAHA, if there's any drop in the hemoglobin, and that's when you can intervene early. I think Dr. Mishra's asked me to switch on my video. Unfortunately, I'm like traveling and I'm in the dark, so you're not going to be able to see much.
Yeah.
Any other questions, sir?
Mishra sir, do you want to add regarding pregnancy associated TMA, because that poses a challenge? They may be having overlap with the classical cases that we see regularly. Is they have like the pregnancy-induced hypertension in the last trimester. Probably they terminate the pregnancy. Sir, yeah, we can't hear you, sir. Please unmute.
Sorry.
Yeah.
Actually, we had few cases where we initially suspected to be HELP and preeclampsia. We have delivered the patient. Patient continued to have anemia. There was some signs of MAHA and AKI. And in these cases, actually, we are publishing one of the case report also. After starting plasma exchange, there was a significant improvement. Unfortunately, we don't have like eculizumab and all. Maybe that would have been more effective, because in pregnancy, in those kind of cases, we suspect more of a complemented mediated TMA more than TTP. So, but plasma exchange helps. When you have a doubt, as Dr. Madhav told clearly, in 40 to 72 hours, things are not improving, persisting to worsen, you have to think of plasma exchange. And this is not only kidney, maybe liver dysfunction might be there, the persistent anemia, LDH becomes very difficult post-pregnancy, because LDH anyway will be high. If they are undergoing cesarean, then even it becomes difficult to rely on LDH. But progressively increasing LDH, yes, there is a problem. It may be high to start with, but if it is continue to increase, then there is a problem.
Yes. So, Dr. Madhav sir, yeah, basically, as you were telling about therapeutic plasma exchange. So, what do you think? Generally, what we use as the replacement is the plasma. Do you think any alternatives are there, sir, to use as a replacement solution, and any comparisons between different plasma products and all?
See, I always make sure I
Your voice is
more
breaking.
on most occasions we use FFP.
Yeah. Now it's fine, sir. Yeah. Go ahead. Hello, Madhav sir.
Can you hear me, sir?
Yeah. Now it's
Can
fine.
you hear me?
Yeah. It's now.
Yeah. So I always have a conversation with my transfusion medicine head before going ahead with deciding on that, right? On most occasions, we do go ahead with FFP, but there are alternatives. You could go with like a cryosupernatant, or you could go ahead. So the whole point again, so the whole point of this, there are a lot of trials that have looked at plasma infusion versus plasma exchange alone, and plasma exchange is definitely better. I think on most occasions we would go with FFP, because in addition to removing the autoantibodies, you also want to be replacing the ADAM TS13, right? So FFP is what we choose on most occasions. And also, I've come across another question in the chat. Should I answer that? There's a
Yeah, sir.
question that's
Please
been
go ahead.
posted
Yeah,
on the
60.
chat.
Yeah, 66-year-old
Yeah,
male.
so the question is that there's a 66-year-old male with AKI, the renal biopsy showed TMA, had no other features of anemia and thrombocytopenia, and renal parameters improved after hemodialysis. And without plex, later he had acute lacunar cerebral infarct. Will adding antiplatelets alone suffice? So if you look at the guidelines for treating TTP, there is mention of always adding antiplatelets whenever possible. So that is part of protocol. Actually, you could add antiplatelets, and if you also feel that there is any necessity to add anticoagulation prophylactic, you could add that as well. And you may have the odd case that will improve without doing plex, but when you have a condition that has mortality, if not identified on time and treated appropriately, I think you should always see what's at stake when when you want to decide between going ahead with plex versus not going ahead, right? So you might overtreat a certain patient, you might do plex for a patient who would have improved otherwise. But if you're reluctant on starting plex, right, the chances are that you lose more patients than you save. Right? And I hope that answers the question. You've had a patient who's improved with hemodialysis, fine. You've had lacunar infarcts, definitely go ahead, add antiplatelets. But if the suspicion is, I mean, obviously this case was difficult, right? You had renal involvement, you had absolutely no anemia, thrombocytopenia. So you've done a biopsy, but now I don't think a lot of people would go ahead and make a diagnosis of TTP if you had someone who was just present with acute kidney injury and absolutely no cytopenias, right? But there's no mention of whether any cystocytes seen on the smear or anything.
Yeah. Yes, sir.
Okay.
So
Anything else? I hope that answers your question.
yeah, I think fairly it's fine, sir. Yeah, TMA doesn't mean like because other features are not there probably.
Dr. Madhav, because in
Yes,
this
sir.
case they presented with a creatinine of 10 and required dialysis with a TMA, it may be a complemented mediated also, right? But
Yes.
the thing which goes against is presenting with a stroke. So I'm not sure like ADAMTS13 will help in these cases.
Sending ADAMTS13.
So at what point would you have sent ADAMTS13 for the patient? I mean, so what was the, can I know what the initial diagnosis was, the working diagnosis when you saw someone with acute kidney injury and nothing else, no other relevant history?
Yeah.
Normal, complement normal. It's very difficult actually. So as you told, there is still a possibility that it can be TTP. But in these cases, to think of starting a plasma exchange, shall we send in this kind of cases and ADAMTS13?
There's no harm, sir. You could always send it. Again, I'm sure if you had no other reasons for the AKI, we would have gone ahead with the biopsy. It could, like you said, some cases are associated with a myeloma, and if you cannot explain the raised serum creatinine by other methods, you would go ahead with a biopsy. In this instance, you found a TMA. There are other instances where you would go ahead and find, an evidence of a plasma cell dyscrasia, right? So we would have definitely, the only way we would have made a diagnosis of TTP in this case is with a renal biopsy.
Yes, sir. So one interesting question, sir. Suppose any patient coming with Jehovah's Witness, as you know, they don't accept the blood products. So
yes,
do you think any other alternative is there for them, like any recombinant ADAMTS13 or of course, caplacizumab is one thing which may be an option, but probably it's not very available in India. So do you think anything can be done? Because we had recently one patient, of course, it's not TTP, but we had a patient with Jehovah's Witness where we tried giving other things to improve his condition, but we do sometimes come across these type of patients. So what do you think? How to?
I've actually come across quite a few Jehovah's Witness because during our training in Canada, right, that was a very common situation we encountered. And I think to an extent, you should thank them because without them, there wouldn't have been as much research to try and find other ways to treat these patients instead of blood products, right? So see, even in a Jehovah's Witness, personally, you could
Madhav sir.
where they finally agree to get it done, right? And you should try and make them understand. See, but you should try and tell them what the other options are. If you're not going ahead with blood products, what is the other option? Say, for instance, there are some clinical trials which are looking at taking these patients to a transplant, even for an autologous transplant at least, where we start them on erythropoietin stimulating agents even before the transplant, start them on thrombopoietin agonists before the transplant, so that we try and see if that can avoid giving them transfusions, platelets or blood products during the transplant. So that's a different context, but I'm just giving you an example how things are managed. Over
Yes.
here again, if you're asking specifically about TTP and in the context of transfusions and these things, you have to make them understand that whatever remaining options are there, you're not too you have to convince them, or at least try and make them understand that these are the options. There is no guarantee that these might work, and this is what's at stake. But I think beyond a certain point, you cannot push them to do certain things. And I've had so many patients who were denied an allogeneic stem cell transplant because they refused, products. You cannot take a patient to a transplant, an allogeneic stem cell transplant, and not give them any blood products, right? So unfortunately, that's the situation. And Ritux is really like our, our the poor man's eculizumab, right?
Yes.
Even in the West, having access to eculizumab is not that easy for countries that still rely on the government to support it. By the time you write a letter and seek eculizumab, you would have lost the patient. So Ritux is really like the poor man's eculizumab. Rely on immunosuppression, give corticosteroids, and I think that's where the options end.
Yes, sir. Yes, sir. As we were discussing, like about sometimes there is a refractory, suppose 3, 4 plasma exchanges you've done, probably did not expect much, like did not improve the platelet count much. You contemplated giving probably rituximab. When do you think session giving rituximab during plasma? Anyway, you're planning to do further sessions. Is it removable during plexer? Like how
See,
to dose it?
see, coming to think of TTP, I feel other than knowing what all conditions could possibly cause TTP, there's not much clarity as to any protocol, even like treatment wise, right? So rituximab, that's a very good question. So when you're planning flex, right, the best time to give rituximab is immediately after a session of flex,
Yes.
right? And try and maintain at least a 12-hour time frame before your next session of flex. I know at least in our setting, we don't do plex, we don't go ahead and do plex twice a day, but that is possible. You could still go ahead and do plex twice a day. So try and maintain at least a 12-hour time frame after, giving rituximab before you start the next section of plex. At least the exposure to rituximab, although it's not as good as without plex, I mean, it still at least ensures that there's a reasonable amount of ritux still left. Again, even when you give rituximab, we do follow different protocols for ritux. For instance, you could go with a 375 milligram per meter square once weekly, give it for 4 weeks, and then wait. But that protocol is not standardized. So we don't even have a standard ritux protocol for TTP.
Yeah. Yes, sir. Yeah. Very okay. Any comments do you want to add, sir? Misha, sir?
And I think Dr. Madhav, when it comes to treatment, he will be the right person to answer. So there was an interesting question again from one of the listener. How long a patient with TTP without plex can survive?
Few minutes, few hours, few days.
So there is a high, this totally uncertain. You cannot predict it. But TTP, if you are diagnosed TTP and you are very sure about TTP, these people can die at any given point of time. And even if they are looking stable, also they are not stable. Better to think
Yes,
of
yes,
early.
yes. Also, no, just on another note. On another note, it's actually very frustrating, to treat patients with TTP. They might forget. I mean, okay, TTP. So patients with TMA, right? Once you've exhausted your options, it's very frustrating to treat them because they're on multiple antihypertensives, and their creatinine is kind of not improving. You cannot do much in terms of improving their platelet counts. They're continuing to need transfusions, and it's a very morbid condition, I would say. So in a lot of instances, at least in the transplant setting, we try and ensure that we make a very early diagnosis and discontinue the offending drug. That is one very important point to me, because there's a long list of drugs that could cause TTP, right? So we have to be very vigilant and suspect it early, because withdrawal of the offending drug is very, very important in terms of drug induced TTP.
Yes, sir. I think there are any other questions from the audience, sir. Do you want to add any final comments, sir, Mr. Sir?
I think what I believe is, for our people who are from critical care, the TMA is not that uncommon. Maybe we have to suspect more often. In a case who are having unexplained anemia and thrombocytopenia, at least we need to see the peripheral smear, the easiest thing what can be done. The peripheral smear showing significant amount of cystocyte. What do you mean by significant? That is again a questionable thing, but anything more than 2 to 4% is significant. If the cystocyte per, like 2 to 4% per high power field, actually with one field, if you are seeing 2 to 4% of cystocyte, it is significant, then you need to suspect TMA. And maybe like there are many other reasons. Let's see, the common antibiotic what we use, the common infections what a person can get in any, let it be an ICU or in a community-based center also, that can land, that the patient can land up in thrombotic microangiopathy. So we have to be maybe suspecting more often. Few people may have some not like overt all the signs of organ dysfunction and all. There may be some subclinical cases what we can miss, but if you see more often, cystocyte is not that uncommon in case of an ICU patient. So we have to be like more and more vigilant when it comes to a patient who is having some persistent anemia and low growth thrombocytopenia.
Madhav, sir, final comments from you.
Remarkable in present. I mean, it's remarkably diverse in its presentation, and treatment is complicated. And the most important point out of all is just understand that, I think if there's one take-home message, don't expect a classical pentad that you go through in your textbooks. And the moment you see unexplained severe anemia and thrombocytopenia, make sure you suspect TMA, talk to your pathologist, ask them to look at the smear, and let you know about the cystocytes, because that's another very interesting thing. If you look at your smear on consecutive days in the ICU, right? There are times when you find cysts, and then on the next day you might not find it, which may believe that it's probably not the cause. But then you to your pathologist and ask them to see the smear, they will spot cystocytes. So be very vigilant. If you suspect the condition, sure you look at this. And today, and with that, thank you for the opportunity.
Yes, sir. Okay, sir. I think with this we'll conclude. We came to the end of the session. Thank you, Mr. Sir, for elaborated and very good presentation. I think it's an interesting topic. So we learned a lot from that presentation. And thank you, Dr. Madhav, sir, for being the expert panelist on our forum. Thank you, Yashoda Hospitals and our digital team and branding team for providing the platform to discuss these things regularly. So we will bring forward more and more such topics in the future. Thank you and tune in, and good night to everyone. Thank you, sir.
Bye-bye. Good evening.
Bye-bye.